Hi guys, today we're going to discuss about the bowel obstruction. That's a lecture for today, so the surgery review, and it's a pretty high yield topic. I want you to realize there's some things here that's valuable for the wards and for the exam, but I'll try to highlight it to you as much as possible. But there are cues on each of the slides that highlights the important material that you need to know at the end of this lecture. All right, so let's start with a case. We have a 71-year-old obese female presents to the ED with nausea and multiple episodes of vomiting, emphasis 1 day. Frequency of vomiting has not changed despite her being NPO. So NPO means she hasn't had anything to eat. You got to be careful when you read some of the notes, especially when you're on the wards. After a careful history, she was found not to have any bowel movements and has not passed flatus since the onset of symptoms. Her vital signs show a low grade of fever, 100.9. Remember, fever anything about 100.5 and above. Blood pressure is 110/80, and heart rate is 130. Her physical exam shows dry mucous membranes, and she appears uncomfortable. Abdominal exam, she's distended. Bowel sounds are high-pitched. And the labs are remarkable for white blood count, so 15,000. As you can see in the case, I didn't give you much information, but I gave you enough information to come to the diagnosis. Once you see these labs and these history, what do you think is most likely diagnosis? Well, as you can tell, our lecture is about bowel obstruction, but it's specifically about small bowel obstruction. What in the history gives you that idea? This patient is suffering from small bowel obstruction because in the history I told you she has distended abdomen, there are high-pitched bowel sounds, and unrelenting nausea and vomiting. Even though she's NPO, she still is vomiting. That's a very worrisome sign. Her vital signs, you got a low-grade fever, she's tachycardic, and her blood pressure is relatively low for a 70-year-old female. You got to think, when you look at a blood pressure, don't think that, 110/80, 120/80 is always normal, right? What do you think for a normal blood pressure is for a 78-year-old? According to JNC8, actually, it's tolerable up to 150 systolic. So 110, 120 for a 70-year-old is actually kind of low. I'll get worried about that, unless that person is, exercising, is a bodybuilder. So all these signs tell us that this is a sick patient, right? So the first high yield information. It's called the cardinal signs of small bowel obstruction. Anybody presents with nausea, vomiting, has not had any bowel movements, and had distended abdomen, plus not passing flatus. When they say that to you, every time, it's a small bowel obstruction should, pop into your mind. Today we're going to discuss multiple times in number 4. There are 4 cardinal signs: abdominal pain, vomiting, constipation, obstipation, and that's going to lead to not passing flatus, and abdominal distension, right? Constipation is a relative term. So when somebody's constipated, I'm not going to the bathroom as usual as I did. No, I go, every 3 days. That person might be constipated because they usually go, let's say, once a day. Obstipation is complete absence. So I have not had any bowel movement. I have not passed any gas. All right. So, and then, just an interesting idea. When you do a search on Google, it's about small bowel obstruction. Here it goes. 4 cardinal symptoms of bowel obstruction: constipation, distension, vomiting. All right. And we'll talk about large bowel obstruction versus small bowel obstruction later in the lecture. All right, some small bowel obstruction facts. You got mechanical, so by definition is a mechanical obstruction of the passage of intramural contents in your small bowel. What are some of the causes? So this is where it becomes important when you read the question stem, because you get a history of surgery versus no surgery, and that will guide you in what's the cause of this. So usually when they ask you questions on small bowel, is either they're going to ask you what's the cause or how do you manage it, right? So you got to recognize it, and then you got to realize what's happening, right? If somebody had surgery, it's highlighted in red, adhesion is most likely the cause, all right? I would remember that. Then hernia and cancer. Now, if they didn't have a history of surgery, then you got to evaluate hernia versus cancer. This is where your judgment comes into play. For example, if you're reading a case and it's a 75-year-old female and she's coming with small bowel obstruction, and nowhere in there they tell you that hernia is there, so should make you think it's cancer, right? And the shelf is notorious for giving you 2-line questions with much information. And this is where you got to use the most common reason what's causing this, right? There's a there's subtle hints in the questions that they give you. For example, they might tell you this patient has been pregnant female and delivered 3 kids. Maybe she had a cesarean section. So you got to watch out for those. Age and H&P will guide you to where you need to go. So the rule of thumb that you develop: if somebody had a small bowel, if had a history of surgery, and if they got a small bowel obstruction, it's most likely causes adhesions, right? And questions them tell you there's a scar on a physical exam, or had a appendectomy when she was a kid, or they'll give you subtle hints. If it's a large bowel, that should make you think it's cancer. If somebody didn't have previous surgery, then hernia is most likely the cause, right? And if it's a large bowel, it's probably cancer. So just use this rule of thumb and go with it. If it's a large bowel, that should always make you think it's cancer. And if small bowel will tell you surgery versus, not surgery. If somebody has surgery, it's adhesions. If they didn't, it's a hernia. So non-surgical patient. So if it's a non-surgical patient that comes with obstruction, that should already make you worried. Now, the questions written on the NBME and the shelves are for U.S. patients. The worldwide #1 cause of small bowel obstruction is hernias, right? And we'll discuss some of the reasons why. But in the United States, people get a lot of screening. They go to the doctor even once in a while, and they get some kind of physical exam, especially in the question. They assume they do that, and they will detect a hernia. So if they didn't have a surgery, that essentially rules out adhesions, right? They're not going to have adhesions. Now, that should make you worried that it's some kind of a non-benign or a malignant process that's going on. It doesn't necessarily have to be a cancer, right? It must be some kind of underlying disease. And on the exam, you see an elderly patient, somebody who's like older than 60, and they come in with a bowel obstruction symptoms, either large bowel or small bowel. That should already make you think cancer if they're not a non-surgical patient. Here, what the adhesions look like, and put a laparoscope in there. You look at these adhesions, it's just and if you could just imagine if there's a bowel stuck right there, it's it can get obstructed. So that's why it's a very common thing that you see in surgical patients, especially with head surgery. So the 4 signs. Remember the magic number that we talked about? So we're going to get to the number 4 multiple times. We're going to discuss it multiple times today. So why are we worried about small bowel obstruction? Well, the big thing is small bowel obstruction causes strangulation. Strangulation essentially means that it's ischemic and a dying bowel, not a necrotic bowel, but ischemic, it's about to die. The 4 big signs that you need to worry about. So usually with small bowel obstruction, what happens is people are like, oh, my belly hurts, it's distended. But if they say like, oh, there's a specific part that hurts, that means that specific part of the bowel is actually getting necrosed right now. So you should start getting worried about it. If they have fever, if they're tachycardic, and if they're leukocytosis. Now look, there's no blood pressure here. So once again, so blood pressure can be very misleading. So if they have localized abdominal tenderness, fever, tachycardia, and white blood cell count, then this already should make you think strangulation. And then once you get this down, it's going to be very simple after that. Then there are other worrisome signs that could guide you with the answer was acidosis, but a lot of stuff that can cause, lactic acidosis, dehydration, and everything like that. Or peritoneal signs. It just adds to your, answer choice. It guides you with the answer choice. But remember, those are not very specific. But the 4 signs that will guide you to the answer. So let's really think about why do you get a strangulated bowel and that becomes ischemic in a small bowel obstruction? So if you think about it, right, bowel is a little cylinder. You get obstructed, right? Anything, before the obstruction is just going to start distend, right? And it's going to distend. The pressure inside the bowel is going to get so much that you're going to block first the venous outflow, then it's going to go so high that you're going to block an arterial inflow. So essentially, you're just strangling the bowel, right? And they're not going to get a flow. And obviously, if there's no blood flow, it's going to die, right? You also think about it, right? What do you think a bowel will do if it's obstructed, right? It's going to get dilated before the obstruction, and it's going to bowel try to push it through the obstruction. So what happens? The pressure builds up proximally, right? Everything backs up. You vomit. And also with, as you saw on the physical exam, you get increased bowel sounds, the tinkling, the rushing, right? It's because the bowel is trying to, peristalsis to push all those things past the obstructions. So that's going to make you think about that. All right, we're gonna go over this chart a lot, right? But just to prove the point why the 4 signs is very important, because as soon as you saw the 4 sign, the signs and symptoms of strangulation, as soon as you see that, you know your answer is gonna go to the OR, right? We'll go down the list, but essentially just remember the 4 signs. You have localized abdominal pain, you have fever, leukocytosis, and tachycardic. You see that? Bam, you got to go to the OR. It tells you that something is bad going on inside, for this patient. So how about labs, the common labs that you're going to see on the exam? So just don't forget the bad signs, right? But then don't get tricked by the lab, right? You get elevated hemoglobin hematocrit. Don't think that it's a pheochromocytoma. What happens when you lose a lot of volume? You lose, your plasma gets concentrated, right? So your hemoglobin and hematocrit is going to increase. They become more concentrated. Hypokalemia, hypochloremia, and alkalosis. Why does that happen? We're going to go over this more on our fluid lectures, but so when you vomit, the gastric juice is high in potassium, high in chloride, right? It's a gastric juice, it's acidic, right? So you vomit that, you get alkalosis. There's a lot of chloride inside the belly, so you get hypochloremic, right? And remember that if you're dehydrated, you're vomiting all the time, you can't tolerate anything. So your creatinine and BUN are going to go up. So you get BUN to creatinine ratio more than 20, my apologies. Then you get pre-renal azotemia. So essentially you're just dehydrated. So watch out for those. The basic science, the basic medicine comes back into surgery as well. All right, so let's talk about some of the high yield imaging, right? So this is called multiple air fluid levels. So essentially what it is, you get bowel gets obstructed, water kind of goes on the bottom and the air rises, right? Otherwise, in a normal belly, right, your bowels constantly peristalsing, right? So it's mixing air and water. So they're all over the place. But here the bowel is not, the intestine is not peristalsing, so the water settles and the water rises and the air rises above it. So essentially you get this line, it's called the air fluid level. So you see that right there too, and a little bit right there. Okay, so when you see that, you start thinking about small bowel obstruction. Now you gotta be like, well, on the exam, if you see something centrally, always that should make you think it's a small bowel. If it's a large bowel obstruction, it'll be on the periphery, right? Centrally, think small, the large bowel obstruction will be on the periphery, right? So here's a little comparison. This is a large bowel obstruction. We'll have a lecture on in the future about what causes large bowel obstructions, but essentially some kind of it'll be on the periphery. So it's a large bowel obstruction, and then back to our picture, you see small bowel obstruction would be a little bit more central compared to the large bowel. So there's some high yield imaging findings and high yield imaging words that's going to show up on the exam with respect to obstruction that you might get confused about. So we're just going to go over a couple of them. First of all, the target sign. So we'll discuss more of this in the pediatrics lecture, but essentially if you see a target sign, they're telling you that it is an intussusception. So what happens is the proximal bowel goes into the distal part right here, right, and it creates a concentric circle. So that's an intussusception. If it's a kid, we'll go over the differential, what might cause this, but essentially if you see it on an adult on the exam, it's caused by that should make you think of a malignancy, because there's no other reason that would happen in an adult. The world sign. What is a world sign? As soon as you see world sign, the world sign, you should think of a small bowel volvulus. What is a volvulus? It's when a bowel twists on its mesentery, right? So it's twisting on its own mesentery, on its own blood supply. So you twist enough that it's going to cause ischemia. So common sign, but I would say the target sign is more high yield than the world sign. There's some confusing verbiage on the exam. They might confuse you. So don't confuse yourself. Just stick to the basics. Remember the 4 signs, and there's no reason to overcomplicate the things. So some things that will help you on the wards, not necessarily on the exam. So you get a complete obstruction. That's called a complicated small bowel obstruction. Right, so no gas or stool is passing, or incomplete or simple, some passage of gas or stool. On the exam, they're not going to, belabor the point. Essentially, you need to just recognize what if this case is presenting a bowel obstruction or not. So essentially, complete obstruction happens faster. They give you the air fluid levels because nothing is passing, so you'll have your air fluid levels. Whereas simple doesn't necessarily, because you'll pass some gas or stool, right? And the physical exam is going to be the same that we discussed in the case. So essentially, you don't get much simple bowel obstructions on your exams, because then you could just confuse it with a lot of different things, and they want you to get to the diagnosis. And the whole point that we're going to go over here, if you have a partial or a complete bowel obstruction, the management is still the same, and you go to the OR if nothing is improving, except for the fact that you watch here for shorter amount of time and go to the OR, versus in a partial bowel obstruction, you like to watch for a longer time than a complete bowel obstruction. So let's talk about the management. So you get the 4 signs. Don't confuse yourself. Don't sit there and be like, oh, NG2, no. You got to go to the OR. They're telling you that this bowel is dying and you need to go to the OR right now. So remember the labs. If dehydrated, it's the first thing you got to do. You got to put, resuscitate. Watch fluids lecture to discuss, different types of fluids. Essentially, pick an isotonic fluid for resuscitation, which would be, lactated ringers versus normal saline. Any of those is possible, and they're not going to belabor the point, so it's just going to be one of them, and just pick the isotonic fluid. Then you put an NG tube. Why? Because small bowel obstruction, you're vomiting, you could aspirate, it causes pneumonia, right? So that's bad. You don't want the patient to have pneumonia. They're going mortality rate increases, the hospital length of stay increases. You decompress the abdomen, and you get an abdominal serous imaging, right? So you want to make sure this is it. Then you wait and see. If it resolves within 12 to 24 hours, you continue conservative management. And if it doesn't, then you go to the OR. All right? So sometimes they might trick you with the antibiotics, right? You read in the question, you're like, oh, they said, if there's 4 signs of strangulation, you got to go to the OR. But the OR is not an answer choice. But remember, if the bowel is skimming and getting necrotic, what's most likely is going to happen, right? The stool, right, that's full of bacteria is probably going in the peritoneum. So you want to do some kind of antibiotic coverage. So the best answer is third generation cephalosporin. So cefoxitin works great, covers gram-negatives and anaerobes. And if you don't see that answer choice, they want you to pick something that's going to cover anaerobic coverage. So the answer choice with the metronidazole flagyl is the most likely answer there. Be careful. So sometimes they might trick you with the questions, or you put an NG tube and give fluids, right? This might show up on the exam, but this is very high yield for the wards, right? Small bowel obstruction in a patient who had a room-wide gastric bypass is an internal hernia until proven otherwise. They go to the OR no matter what. You don't put an NG tube in. Now let's look at a picture. In a gastric bypass, right? You essentially disconnect the stomach, so you make a little stomach pouch so you don't eat as much, and then that connects later into the bowel in the jejunum. So you bring the jejunum behind the stomach, and remember your transverse colon is right here, right? It goes right under the transverse colon and attaches to your little stomach that you have here. If you put an NG tube, you're not going to decompress as much here. This is a small bowel. It's not going to do anything, right? And it's already bad. It's like right behind there. So the little internal hernia is right under the transverse colon. Your small bowel, your jejunum is getting stuck there. So essentially, as soon as you see that, there's no need to put the NG tube in there. You want to make sure that you resuscitate and you go to the OR. Some practical info for the wards. So realize that 60 to 80% of patients will resolve their small bowel obstruction on conservative management. And that's why we do those things, and that's why we don't just willy-nilly take the patient to the OR. So when should your attending asks you, when should you take out the NG tube? So realize that stomach makes about half a liter to a liter of fluid a day, right? And you see that if the NG output is less than 500 cc's, that means the stomach is pushing that liquid downstream. That means you could start taking it out. So that's the 500 number is a magic number. All right, so let's go over the whole chart about and how to manage the small bowel patient. We already discussed most of it, right? So patient comes in, signs of small bowel obstruction, right? Are they clinically stable? What does that mean? Do they have the 4 signs? If they don't, that means they're not stable, so they go to the OR. If they're stable, you do abdominal x-ray to make sure that is a bowel obstruction. And if you see that it's, the bowel obstruction looks bad, looks like, on the CT scan or the x-ray, it looks like there's bowels dying and you spilling stuff, then you go to the OR, obviously. If it's a complete or partial, remember you said for the exam, don't worry about that because essentially it guides you to the same thing. You put an NG tube, you give fluids, right? And make them NPO, so they can't have anything, right? Obviously they're going to vomit it out, but the NG tube is going to suck it in, right? If they improve within 24 hours, 48 hours, then you just you follow it, take out the NG tube and start feeding them. If not, then you go to the OR. So some points for the exam. These are something that might be confusing, but these are high yield points that'll guide you to the answer. Small bowel versus large bowel obstruction. Large bowel, obstruction develops over a longer time, so it's not, patient comes to ED, it's like a longer, like couple of weeks to months, right? One kind of keyword that they're going to tell you about a large bowel obstruction is a fecal and vomiting, right? Because the contents in the large bowel are, they're about to become stool, so they come to back up and you start vomiting it up. So that's like the key word that you need to worry about. So what do we say for the large bowel obstruction? If it's a surgery versus non-surgical patient, makes you think colon cancer first. Then diverticular disease or volvulus. And then we'll have a lower GI lecture on these, and we'll discuss how to pick which one out. Other causes of small bowel obstruction. On the shelf, they're not going to tell you, is this a small bowel obstruction or not. They're going to see what might cause this, right? Can you understand that there's some other reason that's causing this? We already went over some of them, right? We said if this is not a surgical issue, right, then it's going to be probably some kind of underlying disease. If somebody who had a surgery, then you think adhesions. But non-surgical patient makes you think there's something serious going on underneath it. So first one, Crohn's disease. So common words, terminal ileitis. So the terminal ileum gets inflamed, and and the patient's like, oh, in the past they took me to the OR, I had appendicitis, but they took it out, but I'm still having some symptoms. It causes strictures in the bowel, so you might get small bowel obstruction in multiple different places. If you see perianal fistulas, that essentially tells you this person has some kind of Crohn's disease. History of ulcers in the mouth. Remember, ulcerative colitis, as we'll discuss in our future lectures, is from rectum to the large colon, right? Versus, ulcerative Crohn's disease is going to affect anything, and it could affect all the way anywhere to the GI tract. And one of the things they tell you, they have multiple ulcers in the mouth over the couple of years. And chronic weight loss. These patients are on multiple drugs, and the bowel is injured. They can't eat properly. They're not nutritious, so they lose weight. So watch out for these signs, and it might tell you, oh, that could cause a small bowel obstruction. So let's read this case. You have a 45-year-old female who presents to the ED with nausea, vomiting, and abdominal pain. Has not passed any flatus or stool in the past 24 hours. Abdomen is mildly distended with high-pitched bowel sounds. Vital signs within normal limits. And it caused a history of pain in her right upper quadrant, which was evaluated in the past, right? But then she was lost to follow-up to financial. So this is a common thing that you see. The patient, came in, and they, with some past, and they just for a long time hasn't, followed up with the physician. And here in the picture, you have her previous X-ray and current X-ray shown. Essentially, you could recognize this one, right? What is this picture? We already discussed this. You have the multiple air fluid levels right here, right here, right here. So this is, you see it like essentially a horizontal line. Whereas you don't see it here, but you see it here. There's a horizontal line with the air above it. So that tells you small bowel obstruction. But this is our previous X-ray. So essentially, if you look at this, you're like, oh, this is probably normal. This is a lot of, this is how it's supposed to look like. You see the lines, you see the bowel, you see a lot, had a lot of, stool in her belly. Pay attention to this level, though. So this is like a tricky thing they might get you at. So they're not going to show you this X-ray on the exam, but this is what you see this air in the liver right here. Well, that is called portal venous gas, right? So this patient had gallstone ileus, right? So gallbladder gets inflamed so much over a long time that it makes a fistula between itself and the second portion of the duodenum. So it's a duodenum. If they ask you a question on this, it's going to get attached to the duodenum. So where does the stone get lodged? The smallest part in that in the small bowel, right? Where is that? That is at the ileocecal valve, right before the cecum, right? It's like it's ileocecal valve will control it. So it's going to get lodged there. Essentially, you're causing a small bowel obstruction there. It's not because of adhesions, but it's a stone that's causing it. You obstructed it completely. That's called pneumobilia. So you look air within the biliary tree. That's exactly what this is right here. You can kind of follow the vessels and the portal vein right there, but you can't tell exactly where. But you can see the vessel, the air within the vessel. That's not normal. So what do you do for gallstone ileus? So you remove the stone from the terminal ileum. Obviously, that's causing a lot of the symptoms for the patient, right? If they describe the patient as like the blood pressure is not good, the heart rate, the patient is coding, the vital signs are not stable, then you just leave the gallbladder. You'll come back to it later. If the patient is okay, removed it, the vital signs are stable, then they're described as, they're not at risk. So if they're describing like a 40-year-old female who's otherwise healthy, then you probably take the stone, you take out the gallbladder, and you fix the duodenum. If they describe like an 80-year-old female who's not going to tolerate the surgery, then you just remove the stone and leave the gallbladder intact and come back to it later if you can. Hernias. So we have a separate hernia lectures, but hernias are one of the biggest complications of hernias is a small bowel obstruction, right? Most common cause of small bowel obstruction in the world is a hernia, right? But not in the U.S. Remember, he said probably people here go to the physician at least once in 5 years, and they'll get evaluated. And even if they have a bulge, they come go see a physician, right? But no matter what happens, if the small hernia causes it versus adhesion, you got to remember the 4 signs. What were those 4 signs? The 4 signs were a localized abdominal pain, and in case of hernia, it'll be right where it is. And they might even tell you, hey, the hernia size is becoming red or pink on the skin. That means just that piece of bowel that's stuck in the hernia is getting necrosed. That's another sign for it. It's a localized abdominal pain, right? You got leukocytosis, tachycardia, and fever, right? The 4 signs. That just tells you it's strangulated. And then what do we do for strangulated bowel obstructions? You go to the OR no matter what. Right, and then stay tuned, and you could go watch the hernia lecture, which kind of cover some of the basics of hernias. Target sign. Back to the target sign. Suggesting deception in adult malignancy. We'll talk about it in pediatric section. So you see that, just pick intussusception, and we'll talk about why. Don't get yourself confused. Sometimes they might describe you a patient that's have an ileus post-operatively, and then you're thinking small bowel obstruction. Chances are during the operation, adhesions take a long time. They take years to months to develop, right? So 30 minutes after operation, you're probably not going to have an adhesion to cause small bowel obstruction. You can, right? Somebody gets into the bowel, causes an injury, that might be it. But they might frame it as that way. But they're kind of getting you at a postoperative ileus. So what are the differences that you need to look over? The patient is on opioids for pain. Now, remember, postoperative ileus, right? Opioids cause, decrease in your peristalsis in your bowel, right? So you're not going to have a lot of bowel sounds. Versus in small bowel obstruction, remember that bowel is trying to peristalsis and push it past the obstruction, so you have increased bowel sounds. And the whole point is you do not operate on the ileus patients. You just stop the opioids, give him some NSAIDs, make him ambulate, right? And then it should resolve on its own. And it's a common, trivia question that you get asked on the wards, right? Which part of the, bowel wakes up the first? So it's a small bowel that wakes up first, then the stomach, and then the colon. Okay? So small bowel first, stomach, and then colon. Right, about within 1 day, your small bowel starts peristalsing. A little bit after that is your stomach within 24 to 48 hours, and the colon can take 3 to 5 days. So that's why you see those postoperative patients just being just laying there waiting until they go to to the bathroom. All right, so before we finish, let's go quickly over a case. Right, so we have a 55-year-old female who presents to the ED with nausea, vomiting, and severe abdominal pain. Right. Her past surgical history is remarkable for appendectomy, shows a child. On physical exam, her temperature is 100.9, blood pressure is 110/80, and her heart rate is 110. Abdomen is visibly distended with hyperactive bowel sounds. She has marked midline tenderness on palpation. Lab shows elevated white blood cell count of 18, and she has an elevated lactate. So something is going on. She's dehydrated. Her B and the creatinine ratio is more than 20. So what do you think is going on? Now, the question answer is going to give you multiple choices. Put an NG tube, do this, right? But essentially, you're like, oh, this patient has a fever. She's tachycardic. There's a localized pain, and there's leukocytosis. You got your 4 signs there, so you got to go to the surgery. All right? So this wasn't that hard. Just make sure you just recognize the 4 signs. Don't get yourself confused with some of the words that are used, and then just tackle the question. All right. Thank you very much.